طيب بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. نرحب بكم جميعا في هذه الactivity. I'm sorry for the delay in the start for technical issues. If it's possible, if I could have just raise of hand or vote and if you ever use insight to simulation. If you have ever used it, please raise your hand. So we have 29 participant 28, and up to now we have 7, 9, 10. If you've used it, that's great. So we have good. But if you've never used Insight to, okay, thank you very much. Can you please lower your hand? Okay, thank you. If you never seen or participated in Insight to simulation, please raise your hand. Okay, that's great. So we have a mix of experiences, different experiences, and I think this will make it very interesting when we come to discussion. This is I'm talking to you, of course, from Jeddah. Somewhere in one of these buildings, this beautiful large building. I'm in the ground floor of that building. Actually, this is the building at night, as I took the picture a few years ago. And I work with a great team of Department of Anesthesia at King Abdulaziz University Hospital, who provide a lot of support for me. And also, as you know, I'm working with a great team of Clinical Skill and Simulation Center at King Abdulaziz University. Most of the work I'm presenting today and many other times is representing the work that I do with this great team. Of course, as you remember, or joining the society started maybe 4 years ago, 3 years ago now. And it's meant to advance the use and application of simulation with engagement in activities like conferences and other things in the region and internationally. Of course, I work with different capacities with these organizations, but I'm not paid for this event or for selling any ideas. I think most of you know me. I'm the chairman of Anesthesia Critical Care. I'm professor of anesthesia, and also I'm the general supervisor of the Clinical Skill and Simulation Center at King Abdulaziz University. And currently, I'm the president and the chairman of the board of directors of the Society of Simulation Healthcare. And I've been using or working in higher education and assessment application of simulation education and higher education KPIs for the last 20 years in Saudi Arabia. So today we're talking about Insight to simulation. So simulation outside simulation center at the clinical areas. By the end of this 50 minutes talk or less, we will be able to identify the possible sites or choices for sites for simulation areas, the advantages, disadvantage of each simulation location, and apply the concept of simulation program development in systemic manner. I think the importance of Insight to simulation is to, instead of waiting for people to come to the simulation center, you actually go to their clinical sites and clinical locations to show them and to participate with them and let them participate and show the advantage of simulation. As I said, we are the Clinical Skill and Simulation Center. We do a lot of activities here regionally. So it has many key features to use simulation. So in the coming few minutes, I'll show you the rationale, uses, pros and cons, advantages and disadvantages, and the possible different options of variation of Insight to simulation and how to optimize it, and then we'll summarize. Just to start with, and I hope this video will work. So this is an example of Insight to simulation.
Last week I gave a fire safety talk and nobody paid any attention. It's my own fault for using PowerPoint. PowerPoint is boring. People Last week I gave a fire safety talk, and nobody paid any attention. It's my own fault for using PowerPoint. PowerPoint is boring. People learn in lots of different ways, but experience is the best teacher. Today, smoking is going to save lives.
Oh my God! Oh my God!
Fire! Oh, fire! Oh my goodness! What's the procedure? What do we do, people?
Phones are dead.
Oh, how did that happen? Oh my God! Okay, it's happening. Everybody stay calm. What's the procedure, everyone? What's the procedure? Stay calm! Wait. Everybody calm down! No! Anyone? 911. Attention! Employees of Dunder Mifflin! This has been a test of our emergency preparedness. There is no fire. It was only a simulation.
What?
Fire, not real. This was merely a training exercise. So, what have we learned?
So, I'm not sure if you've heard the discussion, but it's inside to simulation. He announced at the end, and you could see the drama even without voice or sound. You could see how much drama and how much practical is this type of simulation. So it is inside to simulation. It's in any simulation modality. That's mannequin-based, simulated patient, task trainers, hybrid simulation. It doesn't matter what level of simulation, high or low fidelity. It could be scheduled or promptu, like it could be in a program like next week, Sunday, we will do at 8 o'clock insight to simulation, or you don't announce it like in Code Blue. You just go to the ward or ER or ICU and start simulation. And usually we use authentic teams. So participants perform their usual role. So everybody acts as his own role. And that's different than when we have confederates in center simulation, in which people could play different roles for different educational activities. So as we know, simulation-based education is widely accepted as safe educational technique. Insight to simulation is supported big time by experiential learning. That learning is facilitated by context of experience and by the system integration initiative for patients, the SEEPS model, which has 5 elements for work system integration, including person, tools, technology, tasks, physical environment, and organizational structure. The technique can be also used to test a new system or any changes in the care, like when happened with Corona or with other new modification. You could always rely on insight to simulation for testing and dealing with new system changes. So as we know, experience, reflection, conceptualization, experimentation, this is the Kolb cycle. This is the way that we learn. The more we reflect, the more we have concepts, the more we could go over this. So people always reflect in action and then reflect on action after. And the reflective practice to build awareness of unconscious cognitive routines and emotional reactions, especially when people finish the simulation, then sit and talk, and then they think about the way that they were thinking during the simulation. And this is the way that people progress from novice, advanced, competent, proficient, expert, masters, according to difference model for skill development. And this is the most important thing. This is also applicable to individuals, teams, or organizations. So the more individuals have deliberate practice together, the more the team could be trained and could be having transfer of experience, and then to reach the level from beginner to master. It doesn't matter either reception or managing critical situations. Individuals, teams, and organizations could always use experiential learning model to progress. And it's always important that we will, whatever we see in clinical environments is behaviors and results. But we know that most of the behaviors coming from learning and reaction, and this is what in situ simulation prompt people to learn, and then that bring it to the surface, whether they're able to manage situations or they were not able to the situation. And that's the beauty of in situ simulation, because you will see behaviors, and then when you sit down and ask people what happened, they will go through the learning and reaction, analyze their reaction, and improve with time. As we know, that confidence and experience is not a straightforward line. People go through the 4 phases, first, second, and third. They become unconsciously incompetent, then they don't know they don't know. Once they have the experience, they cannot manage fire in the OR. They think they could just run away, but there is a patient, there is equipment, there are things. So when you put them through simulation the first time, oh, this is now, their confidence will come down. So the experience they will move, their experience will go up, but their confidence will come down. That's when they become unconsciously incompetent or consciously incompetent. They don't know that they know that they don't know. Before, they don't know that they don't know. Then when learning happens, they become consciously competent, and then with practice, they become unconsciously competent. Of course, the problem is that people can't go from 4 to 1, especially for rare events. If things are not happening, intraoperative fires, cardiac arrest, fire in the ICU, new procedures, difficult airway, those are very rare. So people might go from 4 unconsciously competent, they just do things automatically, to level of being unconsciously incompetent. They don't know that they don't know. So it is very important to maintain regular practice, and that's what happened in aviation and others. And this is the way that the expert team always continue to improve, by repetitive practice. People who are not expert, they will decline their skills, and especially team and technical skills and non-technical skills, communication, crisis management, all will deteriorate with time. So deliberate practice that will happen with in situ simulation or in-center simulation is so much reinforced by going through this cycle, by doing in situ simulation, and that always will perform better performance, because the performance always improve with the conscious reflection. The unconscious reflection, if people just do things automatically without thinking, usually they will function at a lower level. But if they're challenged, they will go up to a much higher level. So deliberate practice is a task with well-defined goal, motivation to improve, have to have feedback and opportunity for a repetitive practice and gradual refinement and performance. And all these things could be done for in situ simulation, because you could always go, okay, let's bring the patient out of the room with who is 300 kilos. So you could simulate this 1 and 2 and 3 times, or how to move this big patient, or how to deliver this patient in a difficult situation. You could repeat till deliberate practice, make sure that everybody is on game with the task. Examples, you could either bring experienced doctors for CME, or even medical students, or residents, or nurses, or teams for basic or advanced airway management skills, using of new medications or techniques we've seen during COVID time, introduction so much barrier devices for airway instrumentation, boxes, plastics. How can you make sure this is safe in the real life, or with subsequent equipment or substandard equipment? You could always try that in situ simulation, make sure things work, and then bring a real patient later. So we know that many centers run anesthesia crisis management or other crisis management courses, because we know crises occur infrequently. Major gaps exist everywhere in performance, especially teamwork, and patient safety usually improve with improvement in technical and non-technical issues. And of course, this has resulted in aviation in crew resource management or cockpit resource management. The same for non-technical skills in medical practice and in anesthesia non-technical skills or other type, or the crisis resource management skills. So we know for managing crises, like what happened with COVID or other crises, we need good skills, technical skills, and also non-technical skills like management, behaviors, teamwork, communication, situation awareness. All these need to be like cognitive components, knowing the environment, anticipation plan, all resources, prevent, manage fixation error, using cognitive aid, team management, leadership, followership. Those are very difficult to train on real life. But if you bring a simulation to real life, you could always see whether people do this. Of course, we always go for teams, and ideally implemented to have multiple teams participating. And usually we focus on for 60% on behaviors and 40% or less on medical technical skills, because you could always use part-task simulation, dedicated courses for technical skills. But for crisis management, insight to simulation, most of the time, of course, you could make it 50-50 like what we've done with COVID. We want to make sure that people have the knowledge and also use them in real life. So you could always make the mix. But usually in insight to simulation, we focus more on crisis management behaviors. This could be done full day or different sessions. You could bring different people at the day. For example, you go to a medical ward, do sessions like that, and then bring different people. These scenarios usually very, very challenging. You cannot make difference between these situations and real life. It really look like a real life situation. And of course, teaching happen afterwards. This is like insight to simulation that done with Ministry of Health a few years ago in Mecca, Medina. Those are في المشاعر المقدسة. Similar courses were done in all المشاعر المقدسة. Those are, I think, in Medina al-Munawwara, also one of the sites for example, in our center here, a few years ago, we had a new program for total body irradiation for pediatric patients for cancer. So those are new area, new monitors, people from different hospitals working, King Faisal Specialist Hospital and university. So many teams, they never worked together. So the team from the center went there with the mannequin for insight to simulation. They gave the anesthetics. Then they provided the whole cares with the whole team members exactly as it will be done in the real life. So this is a good example of the use of insight to simulation in workplace. And this is all the mistakes that could be done, how we care for the patient when we are anesthetizing and far away, what are the obstacles in the way, what we need to be removed in the future, all the fine details, how to turn the patient on prone position, maintain monitoring. All these things were judged, assessed, everybody talked it out. And then when the time comes, the simulation rehearsal was like this. And this was the first case. Next month, we've done the first case. Different people, but most of the people have known about the simulation. They saw the videos, and you cannot actually tell the difference. The real case went so smooth because all the potential problems that could happen with the actual case for the first time in March were avoided during simulation. This is also in 2021, last year, we had a very rare case of in utero exit procedure. So the baby had airway obstruction. So they have to deliver the baby and then intubate before separating the umbilical cord. So everything was simulated. And when you see the real life picture, you cannot tell whether this is a real life or this is the simulation, because when the day come for simulation, it was so smooth, so we cannot tell the difference between simulation and real life, because all the potential mistake that could happen during simulation, and we correct them. So the insight to simulation were actually done with the actual teams in the OR. So what are the uses? Improving team performance in workplace, including individuals and team and organization, as I said before. Identifying and mitigating threats to patient safety, latent safety, system pace. We don't have PPE in this place. Improve protocol, system, and infrastructure. Maybe the phone is not working in that area because it's new. So it always show you even the smallest of the problem. This is, of course, when COVID came, this came up much big to the surface. So how to use system-based for COVID and for intraoperative emergencies, caring for patients in ER, ICU, everywhere in the hospital. And, you know, like we always work as imagined, work as simulated, and then practice this, and then work as done. And we always done that. So we always plan, do, study, act, and insight to simulation has been very, very widely used everywhere, every corner. China, Italy, USA, Europe, Saudi Arabia. In our hospital, we did the same. We plan task trainers. We plan and did a real life preparation. We studied what happened and came up with recommendations. And then in real life, when COVID cases came, we are ready. So we use combination of center simulation and insight to simulation to finally prepare our 3,000 employees in our hospital for the COVID crisis. And that's by combination of center-based simulation and insight to simulation. This is also a very nice study from our colleagues in King Crescent in Riyadh, Dr. Hani Lababidi. They use insight to simulation to test the King Fahad organization as an organization for insight to and the application of Wiqaya guidelines. And they came up with strength challenges, and they use insight to simulation and debriefing to improve their responses. As I said before, aerosol boxes, everything that we had as ideas, like even for Ebola preparation in 2015-16, we used insight to simulation in ER, in ICU, and handover. We just test whether the hospital is prepared for the first Ebola case or the MERS-CoV at that time. So to summarize, the advantages, disadvantages, and safety issues. In terms of advantages, it enables learners to learn about the environment they work and the process in place. So location of the crash cart, airway trolley, what's missing. Of course, learners, they don't need to be adapted to the new environment because they are already in their environment. It's very realistic because it is reality. You don't need a lot of briefing regarding the environment. Easier, more accessible for busy participants. So instead of you wait for them to take time off, they you come to them instead of they come. So when they're free in ER, no cases, you could do insight to simulation in the OR, in the ICU. There is free time, so you don't bring expensive facility. You don't need to book a center, so you could make use of the clinical sites. Of course, if the families are there, and they see that you're doing simulation, they will feel safe because they know, oh, those people are preparing for other patients. And it's free for participants. Usually there's no charges. And it is the most important thing. It shows you what you have in your place and what you don't have. And it provides tailored simulation to case mix and sentinel events that have occurred in the workplace. So we have a disaster, or we have a mishap. So you could reintroduce and retest why these things happen. Maybe the blood bank is just does not connect from this phone. Or to introduce guidelines and protocol as would happen with COVID and other communicable disease to improve teamwork, interprofessional communication with teams working together, and that will bring a lot of understanding. It is very easy to follow up because to rerun simulation until participants perform, you could always redo it again. So you could always build on, okay, we finished this point, you could carry on to follow patient journey. So we brought the patient, like in the Ebola patient, we brought the patient and the relative to ER. From ER, they would transfer to the ward or to the ICU. We followed the simulation from ER to ward or from ER to ICU and observe the patient journey, not only patient care at the facility, but the handover. As you could see in the pictures, the nurses receiving the patient, they did not have PPE. They should have had PPE before the patient arrived, since it's coming as a potential Ebola case. Of course, you could identify a number of potential spaces needed for high fidelity simulation and just-in-time education immediately prior to occurrence of these events. For example, in ICU or in ICU, you have a LB model. So if you have very rare to do LB in newborn, you could have the mannequin there. And when there is a need for lumbar puncture, you could bring the mannequin, do in situ simulation, just practice, or intubation for the newborn. And then once you're okay, you could do it on the patient if that's an elective or you have time. So in or near situ simulation also could be used near the clinical areas. Of course, everything has advantages, disadvantages. Of course, because people will do simulation while they're working, they could be interrupted by pages and for calls or called away if there is real care or real patients need care. It's psychological safety harder to maintain. In the simulation center, everybody who comes and going, there is privacy and confidential debriefing. And in the clinical areas, maybe people coming with cases, somebody will look, see what's going on. So privacy is an issue there. So psychological safety might be low physical fidelity and loss of effect that can be used in same center. Like you cannot make smoke and fire and gas line failure like in the same center, because you could cut the gas and affect real patients. So there is limitation in how much you can use effects to make more advanced scenarios like fire. And of course, their time and cost of setting up and taking elaborate simulation. So if you bring the sim man, the smoke machine, the cameras, the hookup, everything you bring to ORs, that time cost, because you will use it for 1 hour. So the preparation time, usually 2 or 3 hours, simulation is 1 hour, and then to take everything down is 3 hours. So it's not like simulation center, everything is prepared. You could just take 5 or 10 or half an hour to set everything up quickly. Of course, this is not the same for all type of simulation. Some code blue simulation, if you have cameras already installed, you could run it quickly. But these are some of the disadvantages. Also, usually, if you don't have dedicated facility, simulator or experienced facilitator go to the offsite, usually you have a debriefing by the people there or the supervisor. So that could be, they could have limited experience. And of course, sometimes secrecy, can you record video in clinical areas? You know, like you have to go through a lot of logistics. Of course, what if you leave a false drug or simulated drug? And we will talk about that later on. But if you have only simulated defibrillator, and we will talk about that in the safety as well, and you forget it, and then people think this is a real defibrillator. And of course, in the simulation center, usually we use some expired equipment or old equipment as just showcase, not for real use. But in real life, you might be using real equipment. So if these equipments are very expensive or disposable, like disposable fiber optic, if you use it in that in situ simulation, that could be a wasted equipment, or ultrasound and then it get damaged or anything. So you need to be always keeping in mind that could be potential downside of in situ simulation, that you could damage or bring damaged equipment to the clinical area. And we will discuss these, as you will see, in the safety issues related. And these are very important because زي ما يقولوا بالعربي ما تبغى تكحلها تعميها. You want to do safety in clinical areas by improving performance, by doing simulation training, and then you make a dangerous thing by exposing real patients to risky situations. So there is some potential safety issues, and I'll show you this video. You could see it. This is for in situ simulation in our clinical areas.
Sir, please. This is patient. Okay.
Who is recording the events of the CPR? Okay, hold CPR please. Hold CPR, switch roll, somebody else should come forward. Gel apply the gel please. Okay. Everyone should be clear please.
Clear.
Are we clear?
Was concerning for the fire.
Doctor.
Gel applied.
Doctor, please don't take much time. Continue back. Yes. Okay.
Inside.
Okay, everyone should be clear.
Clear, clear. Everybody clear.
Deliver.
Shot delivered.
Continue CPR, please. Continue. Back, doctor, please. Back him, doctor. Doctor, sir, back him, please.
Okay.
First back him. Oxygenate him first.
So, what do you think about the simulation that you saw? This is in ER. Those are people from ER and ICU team doing resuscitation in ER. Any thoughts about what you've seen? And this, you could either raise your hand if you have thoughts, or you could write in the chat. Any observation? You could see this is, we've done this in 2016. And I'm very glad some of those people who are in the videos here, we recently done 2-hour CPR on a patient who discharged from ICU. And I think part of it, they're really good. And I think the training paid off. To see this video from 2016 and see those people doing resuscitation for 2 hours and the patient make it, it's a very good testimony that in situ simulation really improve. So can you write in the chat any observation? Many people around, good communication. Any observation about safety? Really assigned roles? Mr. Nabil Halawani, can you unmute? Can ask, allowed to talk. تفضل دكتور نبيل. أستاذ نبيل حلواني. تفضل.
Yes, I believe there's no side rails for the if unsafety issue. To me, it looks like there is no side rails for the patient.
Yeah, but during CPR, of course, we could discuss that. But during CPR, usually these are down. But okay, that's an observation. But if the patient is stable, finish everything, ROSC, yes. Okay, BBE. Okay, everyone is watching. I like the Mr. Zara Al-Haili. Can you please elaborate? Can you add? Can you, if you can, raise your hand? I will allow you to comment on your first person CPR compression was not effective. Can you elaborate on this? تفضلي.
السلام عليكم. المكان أنا زهراء الهلالي. الاريا المكان الإيد، وضع الإيد، اللوكيشن والكمبريشن ما كانت very much correct. هذا اللي أنا لاحظته.
زي كده صح؟
الشخص الأولاني. الشخص
This is what you mean.
Yes. والشخص الثاني اللي إجا وراها تمام. بس آخر واحد after الشوك was delivered. هذا. Yes, this is the one.
Did you notice also what happened to the bed?
Yeah. Yes, as well. But the last one was very proper after.
See, also the same. See this compression.
Who's recording the events of the CPR?
Yes.
Okay, hold CPR, please. Hold CPR, switch role. Somebody else should come forward. Gel deploy. Okay. Everyone should be clear, please.
So you could see a lot of, you know, like this is a very rich video. You could just go and discuss with the team the fine details. Of course, the fine details you could always discuss and see, you know, like one of the disadvantages or the danger, because it's in the clinical situation. So when you ask the nurse, if you go ask this nurse and this person about the compression they were doing, so what do you think the responses will be? You know, like you show them the video, so or you discuss with them the quality of the CPR, because that's very important. What do you think the answers will be? Like, can any volunteer, what will be the answer? Why did you do CPR? I mean, I noticed that you were doing this. So what do you think the discussion will be? Or what will be her responses? She could say, in real life, I do different, but in the mannequin, I'm not familiar how deep to push. So it could be fidelity issue, or she say, oh, I will do this differently in real life. But the point that if you don't debrief this, you don't know whether she will do this in real life or not. So you need to have the discussion. Of course, as pointed out, there are a lot of things the team have done well. So you reinforce that. And then you could go on and discuss the things to improve all the fine detail, because now everything is recorded. You know, the same, you know, like when they applied the gel for the, the gel application.
Okay. Everyone should be clear.
Areas like then they did not do the sequence. They could say, oh, we did this just because it's simulation, but you don't know whether they will do that like in real life or not. Of course, you expect that will not happen in real life the same way, but you could always not leave anything for chances. So the safety issues, as we said, you want to make it safe. So you always keep safety issues in the front. زي ما يقولوا بالعربي ما تبغى تكحلها تعميها. So administration of simulated medication to real patients, expire, artificial, tap water, contaminated, for coloring, both way. So people could be in the simulation session in situ using these drugs, they leave it. And there's some reports that some people during the simulated session, they had, for example, adrenaline. It's not adrenaline, it's in their pocket. So they went to another case, and they used the simulated medication in another patient. So you always have to have very clear labels for simulation in situ and in center, because you don't want to have any mix between those two, and that's a major safety issue for in situ simulation. Of course, simulation equipments, they might be modified or not being used or obsolete. So you could always bring these simulation equipments to the in situ for defibrillator ultrasound. And then if you forget them, then they have a patient in that area, they could be endangered or endangered by using of these equipments that are obsolete and not working. So you always have to be sure about equipments, fidelity, place, equipment, drugs, inside the physical place, and also in the other contamination of equipment from clinical environment used in simulation. So you could have contaminated, not sterile content brought from the simulation center. For example, we have a lot of expired center line. If you take this to clinical in situ simulation and then you forget it there, people might use it for another patient. So you could always, and you have always to keep that in mind. Of course, you could waste clinical resources and for example, using fiber optic, and then there is a patient need a real fiber optic in another place. So that could be a safety issue. So lack of authenticity might lead errors in learning. See, as we said in the video, learners might observe behaviors that not debriefed. It's okay to do compression like that, or to do the gel like this, or leave the bed moving during CPR. Learn procedure incorrectly due to modification required or interactions with mannequins. They think it's okay to do it that way. Of course, the psychological impact on families in nearby clinical environment. After simulation, usually they will be laughing, people will be stressed, then it will be relieved and discussion for safety. But that could bring safety feeling to other patients in ER or ICU or clinical areas, but that could be misinterpreted. Oh, the patient died, or they have a disaster, now everybody is laughing. So that could be also mixed with, so if there is relatives or other people around, you need to explain this is a learning process. This is simulation, people are stressed, or this is part of the learning that's happening, they're taking care, they're serious, but they're laughing because they're relieved that everything went well and they're learning. So that could be misinterpreted. ايش هم جالسين يضحكوا دوبهم يسووا انعاش ودحين جالسين يضحكوا هل هذا يسووه هو في الطبيعي ولا ما هو طبيعي؟ طبعا نفس الادفانتج اللي قلناها، الناس ممكن يفتخروا انه هذا الشيء يعمل this being done for training and preparation. It could be taken other way around if after debriefing they could be taken seriously by the relatives. ممكن يرفعوا عليكم شكوى، دول يلعبوا في الشغل. So we have different types of in situ simulation. We said modified temp in situ space, permanent dedicated in situ space, near situ simulation space, mobile self-contained cart. So those are different types of in situ simulation. So you could have modified temporary in situ space. For example, one OR room, one ICU room, one ER room could be used now and then. So the cost will be variable, realism will be high, setup ease will be moderate. If you have permanent dedicated in situ space, for example, one operative room or one ICU bed not used all the time, or one critical care bed in ER not used. So the cost will be high to set it all the time. Realism will be high, and setup and between cases or between scenarios will be very easy because it's permanently there. Near in situ simulation, the cost is variable. So if it depends on the mannequin, if you leave an airway or LP, it's different than if you leave a major high fidelity mannequin. Realism will be variable because you could have this near situ in a space in an office, not an OR or ER bed or ICU bed. So the realism will be a variable, and also setup setup ease will be variable. So it could be very complex. Every time you want to bring in a high fidelity simulation, it's different than if it's just ultrasound or a blue phantom, small phantom. So the cost will be, the setup will be variable. Mobile self-contained card, and some people have that. It's like a card with video recording, everything inside, the mannequin in one drawer, the airway equipment in one equipment in one, and you could just move this from one place to other. And of course, the cost will be very low. It depends on the equipment used. Realism, it depends where you take it. You take it to a regular room, meeting room to do simulation, or you take it to ICU or ER bed. So realism will be variable. And the setup for that is relatively easy because you will be using it over and over again. So people will be familiar with. So when it comes to curriculum design, the same principles for Korn's design, general need assessment, learner needs, goal, objective, educational simulation strategy, implementation, evaluation, program, and learner. The same principles that you use to develop any other curriculum design in situ, or near situ will go using the same 6 steps. As you know, you could always, if you have the general goal set up, you could just go for learner needs and go for implementation. If you have a specific goal and objective, you could just do the simulation, go for evaluation. It is not, you could go systematic, which is best, but you could go either direction. The most important thing is that you meet your educational strategies. If simulation is one of it, the aim is not simulation. The aim is having educational strategy that's effective for the goal desired. So if simulation and teamwork and situation crisis and preparation and system failures is your goal, simulation will be, inside to simulation will be the good strategy. The same things, you need to go in-time simulation, you need the need assessment, learning objective, best methods, means for evaluation, all the resources, and planning and logistics setup. So to summarize, insight to simulation is very important. It needs careful planning because there are a lot of advantages for insight to simulation. Program specific training set up to meet the goals. It depends on the problem. So you need to have a challenge or a problem, and that's the beauty. You always have people talking about problems, and then you could, oh, we could use insight to simulation. So it's a key to success is to buy in from staff and inspiration. If you have resistance in your place and you do successful insight to simulation, believe me, people will have more interest to join in simulation. So always assess, plan, train, and reassess. Thank you very much for our great team in the Simulation Center. And I hope the next time we'll have new pictures. I will stop now and I'm happy to take any questions if there are any. هذا إذا ما نومتكم. Is there any questions? If you have any questions or comments or mudakhala, please feel free. And we just took a few minutes after 8 o'clock. Sorry for that, but we tried to make up for the time. And sorry for the delay to start. Can you elaborate, Mr. Nabil, what about debriefing usually happen in the same. We usually like debriefing in other areas, but debriefing happen immediately and in the same place. But you could always do serial number of simulation and then debrief later. Yeah, we do a lot of simulation at King Abdulaziz University Hospital, including anesthesia. إن شاء الله بعد العيد كمان السنة دي حيكون عندنا couple of courses for in the center and hopefully in situ as well. Thank you, Dr. Faiza. And thanks for everybody who's joining us. If you have any comments, if you have negative comments, write it here. If you have good comments, go to Twitter and make it, and in the evaluation, write it. If anything negative or areas for improvement, you could say here. Is there any other question? Is there anything clear؟ ولا كله إذا نمتوا عادي ترى التخدير دكتور هاني.
Assalamu alaikum, Prof. Thank you very much. Very enlightening as usual. MashaAllah. Prof, I just wanted to ask, is there any evidence suggesting that in situ simulation is more beneficial overall as an outcome later on? Is it more beneficial than the sim lab, or each one of them has its own, as you said, advantages, disadvantages? But I'm asking as a, so where shall we, if we have efforts, shall we put it more into in situ simulation? As you know, I'm from the PICU setting, so maybe I'm biased, but I wanted to hear from your good experience and literature, please, Prof. Thank you, Prof, again.
Yeah, thank you very much. You know, there is one study published a few years ago about the return of investment of using simulation, high fidelity simulation for team training. Of course, like it depends on what you're measuring, the effectiveness. What is better, and what are the level of evidence? Is it improvement, or is it satisfaction? Usually people are satisfied with both, but that's a low level. If you go higher for learning, and then the next level will be improvement in behaviors. People, level 3 Kirkpatrick, or the Kirkpatrick model for effectiveness of training, the change in behaviors. And then level 4, that's actual outcomes, the traumas, the fractures, falls, team management, or conflicts. Of course, the higher you go in the evidence, and of course, that study looked at the higher level of evidence, that return on investment. So how much you spent and how much you gained in terms of either better turnover in the OR, better utilization of resources, and the most important also, how much avoidance of complications. Because if complication happen, for example, antibiotic use, if one patient missed one antibiotic and they had mediastinitis post-cardiac surgery, usually the cost, one case mediastinitis, is 2 to 3 million. So how much complication avoided, if you add that to the calculation, of course, the calculations will be very important. So the advantages, disadvantages, and then you do randomization. Usually those studies are very complicated, but there is evidence that high fidelity team training have class 5 evidence in academic centers by increasing productivity, and the most important thing, reduce complications. If you put price on the reduced complication, usually you could cover the cost of training. Of course, as we said, the advantage of in situ training take out the most important cost. The most important cost for center simulation, money-wise, is the time off. People have to come time off for training, and people have to come time off for trainers, as trainees and trainers. You cannot ask people, you come morning shift, or you go night shift and then go next day for training. They have to take time off, and that's money. And also the instructors, they have to be paid extra, or this is counted as their payday. All these things are costs. When you bring these costs back to real life situation, I will do the simulation during my shift. The staff will do the simulation during their shift. So there's a large amount of cost saving is taken away by in situ simulation. The most important expensive thing in simulation most of the time is not only the equipment, it's the setup and the time paid and the time off. Of course, the other food and everything. In situ simulation, you take that out of the. I'm not aware of in situ versus site center, but if you put the numbers, if you think about cost of savings and also not paying people, I think there is a very good, and as you're always planning good studies, we could always plan together one study to look at these things, but it will be, it would require a lot of work. And I think, you know, like if we go for the total body irradiation, how many times you need to bring patients to center that they're not trained and a center that trained and calculate? It will be very unpractical. Or for the exit procedure, these cases are 1 in 3 million. So how can you get enough cases to make the case? But when we did the in situ simulation with maybe over 30 surgeons, anesthetists, nurses, RT, perfusionists, BICU, NICU teams, pediatric surgery team, 30 people doing simulation for one case, but this case is 1 in a million. So how can you make study to see whether it's cost effective or not? So I think if waiting for evidence is the only thing, and especially money and cost saving, which is great if we could prove it, but I think many cases will be lost. I will not be looking for that level of evidence to start using it, but it will be interesting to work towards that goal. I hope I answered a question without going round and round. يديك العافية, شكرا. If there is any questions from other participants or any comments, عودا على بدء, I would like to thank the team from the society, Ms. Safa, Dr. Reem, Dr. Amani, Dr. Rima Mhezei, everybody who participated and arranged for this. And I hope to see you all in other events. And we'll look for your experiences to be presented in such webinars. We're inviting all to apply for talks because I think with such experienced staff and different mixed participants, we could always learn together in these important topics. Thanks again, and hope to see you soon in other events. Thank you all. أستاذ نبيل, عندك مداخلة ولا تمارين الصباح هذه؟ يعطيك العافية, شكرا جزيلا. شكرا, السلام عليكم.